Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care.
Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, co-host of Pop Health Podcast. In today's episode, I had the opportunity to sit down with Chris Johnson, Vice President of Corporate Development at Landmark Health. Now, many of you listening or watching today's episode may have actually served or interacted with Landmark Health patients, but you didn't even know it. Landmark is contracting with funding sources like Medicare Advantage plans or delegated medical groups or health systems to take on some of the most challenging patients who have the most chronic conditions. And their goal? Well, they're actually guaranteeing that they're going to positively impact these patients' lives and save the health plans or the funding sources significantly, or Landmark won't even get paid. So they have a lot of skin in the game. Chris shares about the Landmark model and how they've been successful from the East Coast and now all the way over to the West Coast, going down from Washington to California. They're also through much of central United States as well, and they should be in 25 states come end of 2022. We hope you enjoyed today's episode where Landmark talks about how they invest in sending physicians, nurse practitioners, and PAs into the home of what they call their Joes or Josephines or their patients, and they're visiting them 6 to 8 times per month, investing heavily in those visits, but what is ultimately much more clinically effective than institutionalization or receiving care in a facility. We hope you enjoyed today's episode. Check out other episodes of Pop Health Podcast by visiting us at pophealthpodcast.com, our YouTube channel, Spotify, Stitcher, Apple Podcasts, or wherever you listen or watch your shows. Chris, thanks so much for joining the show today.
Thanks for having me, Gavin.
Absolutely. So I got to know Chris a little bit off the air, folks. You can see in the background a little Red Sox little flag there. So maybe besides the Red Sox or sports, well, I guess you can say something about sports, but what's something about you, Chris, that might surprise the audience? Maybe something outside of healthcare.
It's an interesting opener, Gavin. Something about me, a couple nuggets. One, I'm a avid skier. So my family and I love to ski and be outdoors. And the second is I spent a lot of my earlier years rowing up and down the Charles River.
Okay. The Charles River. Now, tell us where a lot of our audience may not be familiar with that. Where's that located?
Yes. So the Charles River is the major river that cuts through eastern Massachusetts. It separates Cambridge from Boston.
Okay.
If you ever see those images of Boston with a river in the foreground, that's the Charles River.
Awesome. I know we talked off the air. I'll be making my first trip to Boston next week, and it's starting to get a little cool out there. I saw low 40s, a high of 65. I'm from Southern California, so that is cold. That is cold for me. So
yes,
rowing.
You'll need to bring your puffy coat to make sure you're staying in that 75 to 80 degree band.
Thank you. I appreciate that. I'm guessing you're in flip-flops and shorts and a t-shirt in that kind of weather.
Not quite yet. In the spring, when you're coming out of the cold winter, the kids all start wearing shorts when it's like 45 degrees out, because it feels like summer relatively, I guess.
Nice. So rowing, I won't ask you to flex, but I can imagine the muscles. When did you start learning? I mean, I think of rowing as like a college sport, an East Coast thing. When did you pick it up?
Yeah, I started rowing when I was in high school. I went to a small school in Massachusetts that had a rowing program. Funny, I actually showed up the first day. You had to play a sport each season, and I would say I was previously a mediocre baseball player, and they had this sport called crew that you could try out. And I actually thought it was sailing the first day. So I was kind of day one was a different awakening. But picked up in high school, rode through high school, and then also rode in college for 4 years in Boston. So.
Okay, awesome. Let's talk a little bit about that. So you grew up in the East Coast, and getting to know you and looking at your background a little bit, you ended up going to Harvard. What inspired you to look at Harvard as your school of choice?
I grew up in a small town in central Massachusetts. I was the first one in my family to go get a 4-year college degree. So having the opportunity to even get into Harvard was really exciting for me. It was a great academic experience. You meet and are surrounded by a lot of truly amazing individuals that become your friends. And I was also on the Harvard crew for the 4 years that I was there, which was another kind of brotherhood that I've taken through life with me. So it was a really great experience. I think there's probably a lot of stereotypes around what it means to go to Harvard. But for me, it was just a phenomenal education and a phenomenal opportunity to meet some really just fascinating individuals that do things in all walks of life. Some, one of my college roommates is a high school teacher. Another is a lawyer for the provincial government in Canada, working on resource law, and then myself, I guess, being the person who went into more of a healthcare corporate job, but just a really amazing array of individuals. And actually, my wife there, our freshman year, first week of freshman year.
Nice.
Yeah, so
that's awesome.
She stuck around and put up with me for the last almost 20 years now.
Nice. Well, we have listeners and viewers from all over the country, but a lot of them are in the West Coast. And you mentioned the stereotypes of Harvard. So what would you say is a stereotype that wasn't necessarily true, that you would like to share with our audience? That's something you can break the stereotype.
I don't know what all the stereotypes are. I think what I'd more say, Gavin, is I think that there's my experience there was a lot of individuals who are really passionate about changing the world in a whole bunch of different ways. I think I later in life had the opportunity to get a graduate degree in business, and it's another set of really impressive individuals, but much more focused on, I would say, like a kind of like a business focus on the world. I think what the pretty amazing thing when I was in undergraduate is just the diversity of passions and interests that folks had and brought to the table. Some who wanted to become singers and musicians, like I said, some that want to become school teachers, others that want to go into the nonprofit sector, some that want to go into business and finance. I think is maybe the more traditional stereotype of Harvard is everyone goes to Wall Street or becomes a management consultant. But that exists, but there's a real diversity of passions and really inspiring people to be around.
Yeah, no, I think that's a really good point. One of the individuals who backs the show and helps create Pop Health Podcast, Ryan Iwamoto, a colleague of mine, he's actually going out doing a CEO entrepreneurial program. He's there this week, actually, not too far from where you're located. So, and he definitely is maybe not the stereotypical person, but is changing the world. And he's met people in this graduate program from all over the world who are, change makers. So that's a really good point, Chris. So you go to Harvard, you mentioned your graduate degree there in business. At what point in your career did healthcare become a reality or something that you wanted to get involved with?
Yeah, I had the good fortune coming out of my undergraduate degree to work for a professor named Clay Christensen, who was a business school professor who coined the term disruptive innovation. So it's his theories that I think disruption is used quite frequently now, but it was his business theories that came up with the concept of disruption and innovation and how that will shift industries. And I got to work for his consulting firm called Insight for a number of years early in my career, generally focused in the healthcare space. So everything from medical devices and life sciences, and kind of in the latter years, a real passion for payers and provider space. And for me, a real belief that I think the US has a really amazing healthcare system. we're able to cure many diseases that a decade ago were incurable. We're able to reconstruct, parts of the human body for people who have acute injury so that they can go live an unencumbered life. But the thing that I think see over and over again that we struggle with is how to support those members of society who are aging, living day to day with underlying chronic conditions that are starting to impede their ability to live life the way they want to. I think over time we've tried to have the hospital be the core of the healthcare delivery hub in the United States. I don't know if I have enough hairs to proclaim that, but I think I've seen more and more healthcare delivery move to be hospital centric. I think for me, there was always a belief that really good primary care and empowered primary care should actually be the hub of that care delivery. It's just there were forces working against that out there, and a belief that if we could do that well, we could actually really transform just the way that healthcare works for people who are aging and really want to live in place and be in their home, be in the community, be surrounded by their friends, their families that love them, and ultimately be able to pass away at home and not in a facility if that's their desire. And that's just really challenging to do these days. So that's what really ignited my passion, is what brought me to Landmark eventually.
Awesome. Yeah. So let's talk a little bit about Landmark now. So for our audience, many of us may not be familiar with Landmark. We're familiar with maybe the payers or the funding sources that help fund Landmark's work. But briefly give us a little bit of background on Landmark and what you guys are all about.
Be delighted to. Yeah. Landmark is an in-home provider of primary care for seniors with complex illness and frailty. So we partner with generally Medicare Advantage plans or health systems and provider groups that take on full financial risk for their Medicare Advantage members. We then have a financial, like a full risk guaranteed contract that we enter into with those payers or health systems or provider groups, where we guarantee improvement relative to a baseline for that population. So we actually guarantee savings back to our clients and take full risk for downside. So we're at full downside risk, guaranteed savings to our partners, and generally also a construct where we share in the savings if they're in excess of a certain level that we're able to generate for those patients. And we do it via primary care delivered in the home. So we don't have any physical clinics that we see patients in. Our provider groups across the country, and we're in 18 states today. We'll be expanding to close to 25 states, I believe, by the end of the year, next year. Caring for this year around 175,000 patients. We call them Joes and Josephines at Landmark. So you might hear me use that expression because it's so ingrained. And moving to almost 300,000 patients by the end of next year as we grow. And the idea is that patients, especially those who are high frailty and high chronic disease burden, need more access to primary care than they receive today. So the average Landmark Joe or Josephine is about 80 years old and has about 9 chronic conditions. Some have more and some are older, but just to give you a sense of the patient that we're caring for. And we're very specific to care for those patients with high disease burden because we think our clinical model is designed to benefit them the most. And we go into the home. Our average patient gets between 6 and 8 in-home visits with a Landmark provider. And a Landmark provider is either a physician or a nurse practitioner or physician assistant who are going in and diagnosing, treating those members in their home. And they're doing it as an extension of the patient's existing primary care provider. So we coordinate with their the primary care provider they've maybe had for 5 years, 10 years, their entire life, and helping to bring that care into the home where they, the traditional primary care provider can't go. The average landmark visits hour or so in duration. It's at the patient's or Joe and Josephine's kitchen table or on their sofa in an area where they're really comfortable and they can talk about what it's actually like to be living in their home and what support and services that they need in addition to that.
Yeah, I think it's great that you mentioned you're an extension of their primary care physician. I know, my day job is in the home care space, and one of the challenges when we talk about like in-home physicians or doctors, house call doctors, is they don't want to give up their primary care physician. They trust their primary care physician. So the fact that you're not replacing that individual, but serving as an extension of that individual, is something you may have mentioned in Chicago. So audience, I met Chris just a couple weeks ago in Chicago, and I approached him after he was on a panel, because what Landmark is doing is, you mentioned disruptive, and it's used quite a bit, but it really is, and it's making a great impact. So great point again, that you're not replacing the primary care physician. And I did remember the Joe and Josephine's. I have my notes here from Chicago right here. And that was something I was going to ask you about. So one thing I want to ask you about as well is, while a lot of our audience are in leadership positions, some of them are frontline. So they might not in their day-to-day think about the term downside, right? Downside risk. So can you explain how you're taking on this financial risk in layman's terms and maybe walk through like an example of what that means?
Yeah, I'd be happy to. So the way to think about the financial arrangements that we have with our payers is the following. One, we have a tool that we use that says, based on these diagnoses, these are patients who are clinically appropriate for our model of care. We've kind of designed these as Landmark over time. We've refined them a little bit with some of our customers, but it's a fairly standard tool that we use across all of our contracts. The rough way to think about it is, if a patient has 6 or more chronic diseases, so think heart failure, emphysema, vascular disease, type 2 diabetes, if you have 6 or more of those, then you would qualify for the Landmark program if you're a particular customer. What we then do is we look at the population in the year prior, not the actual members, but we actually look at the data that the health plan had in the year prior and say, oh, anyone who would have qualified for Landmark last year, let's look at that population. And we use that to set our baseline. And the baseline that we do is a medical loss ratio baseline or a percentage of premium baseline. Gavin, pull me back if I'm going too deep, but the high level is that in Medicare, you receive a fixed dollar amount from CMS as a managed care plan each year. And then you have medical expense. So you have to pay for services for that member. And generally you want to have a medical loss ratio that is under 100, because if it's over 100, that means that you're paying more claims than you're receiving revenue dollars or premium dollars from CMS. Yeah. So we generally see that the population we care for has a medical loss ratio prior to Landmark that's north of 100%. Sometimes we've seen it as high as 115, 120%. Sometimes it's a little bit below 100, but it's generally in between 100 and 110%. So these are members that the health plan has that they're actually, for every dollar of revenue, they're actually paying out $1.10 of claims for that.
Quick question on that, Chris. Are those hard costs, or does that include like their administrative fees? Those expenses?
That's just the medical cost. So administrative fees and profit margin are separate. So there's some administrative load that would be on top of that, and there's certainly no room for profit at that point on those numbers. We are. So we'll use that as a baseline. So let's just for square numbers say that the pre-Landmark baseline was 100%. We'll make a guarantee on top of that to say, hey, we'll guarantee you make 99% MLR, or 98 or 97 or some sort of step down over time to our health plan. So they're immediately doing better financially. And then we begin to manage those members. And the way that our model works is around really preventing acute exacerbations of their chronic diseases that result in hospitalizations. So what we try and do is get ahead of a heart failure exacerbation, get ahead of potential infection that might be festering, could lead to a sepsis event, and do that in the home with the patient just by being more present with them. So not only are we doing longitudinal care, but we also, patients have access to us 24/7, 365, both from a telephonic perspective, so they can call our clinical triage line, but we'll also dispatch providers into the home 24/7 if it's necessary to help prevent an exacerbation that would lead to an ER admission, which would lead to an inpatient stay. And so our goal generally is to reduce hospitalizations by about 20%. Also reduce skilled days in like a skilled nursing facility. So many of our elderly folks, when they're discharged from the hospital, especially if they're frail, also have a stay at a skilled nursing facility or nursing home for up to 2 weeks. We see about a 20% reduction in days in those skilled nursing facilities as well, and that's a lot of savings, like dollars wise.
Yeah,
that allows us to contract that way. So it's those savings that allow us to provide the financial guarantees to our health plan partners, and also to cover our own operating costs. So we don't get paid like a program fee. We actually have to cover our own operating costs via reductions in other healthcare utilization. And what's really important is it's just better care for patients. This is not, someone should have a knee replacement, we're telling them not to have it. This is preventing a heart failure exacerbation that leads to weeks in the hospital and in recovery. It's really better management of those conditions to kind of reduce those hospitalizations.
Yeah, and that's something that stood out. You mentioned the guarantee again, and that's really what stood out in Chicago when I met you, Chris. There's a lot of organizations that will bill for services and then maybe on top of that get a little bonus if there's savings. But you guys, you have a lot of skin in the game. I mean, a lot, right? And that's what's really impressive. And that's what stood out to me. It looks like you were going to respond to that, Chris.
Yeah, no, I think that's true. I think of there being today, like a lot of people use the term value-based care, and that means a lot of different things. It's a very big umbrella. To your point, Gavin. The interesting thing is our business model is predicated on being able to take that full population risk, because we're a very expensive model, right? Like we're sending some of the most expensive resources in healthcare into a patient's home. It's not an operationally the most efficient model relative to if you park that person in a clinic and kind of cycle the patients through them. That's economically, or not operationally more efficient.
Right.
What we find though is that it's a more clinically effective model, right? Yep. And that's predicated on us being able to kind of put our money where our mouth is and say, we know it's more effective. Here are the patients that we think it's important to deploy this with. And we're willing to go at financial risk to show you that we're not just adding cost to the system, we're improving quality of care. We're helping patients, age in their home and be around their loved ones. And most importantly, we're saving dollars for the health system, for our plan partners. We hope ultimately for the consumer, who will get lower premiums over time, and being able to have ourselves enough capital to continue to grow and fund expansion across the U.S.
Yeah, that's awesome. So let's talk. You mentioned the expansion. You guys are growing. You mentioned hopefully about 300,000 patients by end of next year. So you mentioned, I think, 17, 18 states. Can you share just briefly? I know it's on your website, but maybe to our audience who may not be able to check the website right now, what are the main states you're in today?
It's a good pop quiz. We're kind of all across the country. So, we were founded in our initial market was in New York State. That's probably our biggest market today. We cover just about the entire state with a number of clients there. We have another set of markets in the Northeast. We're big in the middle of the country, from Michigan down to Texas, as well as on the West Coast. We have markets from Washington through California. So it's kind of not regionally concentrated. And our hope and our goal is over time that we can not only be present in every state, but be present in every county in every state. I think like one of the conceptions about in-home medical care and house calls has historically been they only work in very dense urban environments, and it falls apart as you get into more rural locations. Don't get me wrong, we still can't cover rural, like a rural Montana where there's a county with 200 people total in it. But we can go into what I think most folks would consider relatively rural parts of many states. Like I said, we have coverage now across just about the entirety of New York State, which has many rural pockets. We cover most of the state of Massachusetts. It's not just in a place like Boston or Worcester, the two larger cities that we have. It's really the totality of the geography. And that's important. We just, in terms of thinking about health equity, we want to make sure that this is a capability available to folks, regardless, one, where they live, and two, ideally in the future, what type of payer they have, because this is just the right care for them.
Absolutely. So as we wrap up the show, Chris, can you share with the audience maybe an early win or maybe like an early challenge that you guys have had to overcome over your first few years of existence?
Wow. There's almost too many challenges to count sometimes, Gavin. I think one of the things that has been really a key strategic shift that we had a few years ago was, as we were growing, we originally were focused on how do we go to more and more states. We called it planting new flags. And over the last 3 or 4 years, we actually focused on this mantra around density is our friend. And instead of trying to plant new flags always, we're really trying to say, how can we go deeper in geographies where we already exist? For a couple of reasons. One was to really be able to drive operational improvements, like being able to go into more geographies because we'd have more Joes and Josephines to care if we had 2 customers versus 1. Yeah. And the second is to make it a really appealing job for our provider groups. So the more density that we had translated to shorter drive times, translated to happier providers who could, get home with less stress and be home with their families at the end of the day after doing a really, important job by getting this care to folks in their homes. So I think that's been a big one. And, the second big challenge I'll just say is, and I think this might be relevant to some of the folks listening to this podcast, is we're trying to define who we are. It's not clear exactly who Landmark is because we don't fit in the mental model that I think a lot of people in the market have today. A lot of folks initially think that we're home health. Yeah. And we're not. We're partner to home health. We don't do home health activities. We partner with home health in many of the geography and all the geographies where we operate, and see them as really a strategic partner to help keep our Joes and Josephines in the home. And then on the other side, we're not an annual wellness assessment vendor, which is kind of the other box that was an established mental model that people kind of put Landmark in. So that's been maybe the other big victory we've had over time, is trying to carve out this new model of care and create not acceptance, but more awareness of it across the healthcare ecosystem. So that's been a big one that we put a lot of energy behind as well.
All right, awesome. Well, hey, Chris, really appreciate you breaking down who Landmark is. I know a lot of the audience have probably interacted with Landmark patients, but may not have known it. And so, again, appreciate you sharing what you guys are doing, often kind of behind the scenes in the home. So how can folks keep tabs on what Landmark's up to?
Yeah, I think the best way is probably to check out our website. On it, we list kind of all the geographies where we're operating, as well as our who our eligible members are in each of the markets where we operate. And like I said, part of our model is trying to help to quarterback and simplify the experience for our Joes and Josephines. And we're always looking to partner with other kind of mission aligned partners in the communities where we operate. So would really welcome that if you see you're overlapping, and we should connect and get kind of our local teams working to see if there's a way we can really create a differentiated patient experience together.
Sounds good, Chris. And if people have questions for you, is LinkedIn a good way to connect with you, or what would you recommend if folks want to keep tabs on what you're up to?
Yeah, LinkedIn is great.
Okay, awesome. Well, folks, Chris Johnson has been our guest. He is a Red Sox fan. I'm a Dodger fan, but we can get along just fine. I really appreciate you being on the show today, Chris.
Thanks so much for having me, Gavin. It was really fun.
Thanks everyone for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.